kidneys will be subjected to medical conditions which could bring about a hypo-functioning organ. At the same time, your kidneys will also be is also vulnerable to certain neoplastic conditions. Some of these are malignant ones, and some are benign conditions. But all of these neoplastic conditions need to be processed, and most of the time, the ultimate form of management will be surgical excision of the tumor. In some cases, or in many instances, the entire kidney is removed. You have to remember that there are two kidneys that you have, and you can survive with just one functioning kidney. So in the review of your pathologic slides, or in general pathology, these are some of the things that you need to remember. You need to correlate, particularly now that we are starting the second semester, and you have you had a good grasp already of your physical diagnosis. You can correlate your physical examination findings, probably the laboratory results of your patients, to what is actually going on inside your patient's body. So you should be able to correlate the clinical signs and symptoms to the gross and microscopic features that are seen in the damaged organ, or the organ that is having or affected. Now, for the diagnostics, you should also be able to identify what laboratory tests to order, not just that you order all the laboratory tests available in the hospital. So you need to carefully select which laboratory tests are the ones that are important for your diagnosis. And if you recall your physical diagnosis, if you just perform your complete physical examination as well as take a thorough history of your patient, 80% of the time you already have a working diagnosis. So the purpose of ordering a laboratory test is just to confirm what you thought all along. Or if there are some medical conditions that you need to rule out, that is when you order your laboratory tests. So one of the most common medical conditions seen in the kidney is a condition secondary to urinary tract infection. So this is a complication of an untreated or a complicated urinary tract infection. So renal abscess. Abscess formation, it doesn't matter what organ is involved, whether it involves subcutaneous tissues, solid organs, they all present with the same morphologic features. Now, those pearly white structures that are seen in the cortex of the kidney, there are plenty of them, are your microabscesses. Now, you can readily identify that the condition is an acute one because of the smoothness of the renal capsule. More chronic cases, more chronic pathologic problems, will, particularly those that are already or that has entered the stage of chronic renal failure, will manifest, or chronic renal diseases will manifest with fibrosis of the renal capsule. So your Gay-Rotas capsule. So grossly, when you try to peel it off, you will have a hard time separating the capsule from the external surface of the kidneys. But in acute cases, you can readily peel the capsule off. And you will also observe that the external surface of the kidney will be very, very smooth. Unlike in cases of chronic renal diseases wherein there will be areas of scar formation. And in those areas, there's a chance that the renal capsule will stick, or you will have a hard time tearing it off from its adherent surface. Now inside, when you cut longitudinally through your kidneys, you will see this focus of pus collection. So microscopic level, by this time, what do you think are the clinical signs and symptoms manifested by your patient? Patients with renal abscess. Fever, what else?
Pain.
Pain. What else?
Dysuria.
Dysuria or hematuria, pyuria, all those stuff, no? Particularly in cases of UTI or even in cases of renal abscess, patients will manifest fever and chills. So usually it's the chills that will give you an initial diagnosis that this is probably the case of urinary tract infection. It's already complicated. So pneumonia could present also with fever, but most of the time, in my experience, I would readily correlate fever and chills to a urinary problem, particularly an infectious one. So in this case, you can still see a seemingly normal glomerulus at the upper border of the slide. Here, supposedly this should have been occupied by renal tubular cells. But you can see that these are already being damaged. You can barely identify, or you can no longer identify the renal tubular structures. Instead, you will see numerous, a dense infiltrate of polymorphonuclear cells, which are admixed with these larger macrophages. So in cases of, acute pyelonephritis, even in renal abscess, you can see that the adjacent glomerulus most of the time will seem to look as if we're normal. And most of the time, morphologically or functionally, they are also normal in function. Another feature wherein you can see normal glomeruli at the center is a focus of abscess formation. Now, in the abscess formation, the presence, if you recall your cytopathology first topic in GenPath, you will know that inflammatory cells will secrete enzymatic enzymes that will cause hydrolysis of cellular membranes. And this will cause leakage as well as cellular necrosis. Now, in this area of abscess formation, you can no longer know the architecture of the kidney is already damaged. Along the borders, now you have to remember that the abscess will be walled off by an area of fibroblastic proliferation as well as young immature capillary blood vessels. Okay, this is part of the tissue repair and also a response to inflammation. You will notice at this area that there are still renal tubular structures. Some of them will have a necrotic renal tubular cells, the lining. And some of them, inside the lumen of the tubules, these are filled with polymorphonuclear inflammatory cells. Now, when urine forms, and urine will pass through those tubules, when this is extruded out in the form of urine, you will see presence of leukocytes. In some instances, when this will be coated with mucus, you will have your WBC casts. Now, because of the presence of the injury, as well as the presence of the inflammatory cells and their secreted substances, I mentioned a while ago that this will cause cellular injury as well as cellular necrosis, particularly on the renal tubular cells, so that we'll just move on. Next slide. Renal abscess. So your acute pyelonephritis. Your acute pyelonephritis is the initial condition that eventually proceeds to become renal abscess when the bacterial agent is not being treated. So let's just continue. As I mentioned a while ago, that the renal tubules will be filled with the inflammatory cells. The inflammatory cells will secrete hydrolytic enzymes that are toxic to the renal tubular cells. Some of the renal tubular cells will undergo cell necrosis. In some instances, they will also show cellular edema. Again, you can appreciate the glomerulus at the upper border. It is seemingly uninvolved, or it appears to be normal. And most of the time, it is normal. In cases of acute pyelonephritis, you have to remember that it is only the tubules as well as the immediate interstitium that is affected. Most of the time, the glomerulus is being spared. So cellular, the renal tubular cell necrosis, as well as cloudy swelling. I think there's another picture. So some parts of the renal tubular cells undergo necrosis. You can no longer identify the nucleus. Some will undergo, like this one here, undergo cloudy swelling. Again, the glomerulus at the background is seemingly uninvolved. So urinalysis findings, as what I've said, you will have pyuria or WBC in the urine as well as WBC casts. In some instances, the necrotic renal tubular cells will also be passed into the urine and they will show us, or you will observe them as granular casts. The generated WBCs will also become granular casts. So there are two forms of granular casts in the urine. You have your coarse granular and you have your fine granular casts. Then we come to chronic pyelonephritis. What is the most common etiologic agent for, or etiology for your chronic pyelonephritis? Chronic.
Rheumatoid arthritis?
Okay. What's wrong with this X-ray?
Stone.
Very good, because the other section identified it as a lung, as lungs. So those are Staghorn calculi, So section B is smarter than section B. Anyway. So these are Staghorn calculi present on both kidneys. So the most common cause for your chronic pyelonephritis is nephrolithiasis or kidney stones. This is particularly common in areas where the water has high mineral content, or among people who seldom drink water, or most of the time barely moves. So if you are sitting in the office and most of the time you just sit there, you barely stand up or walk around, there's a chance you will be forming stones. There are also people who are called stone formers, and even if you relieve that person of a renal stone, chances are in the later years the patient will still develop stones. Now there are many forms of stones. So anyway, okay, this is a longitudinal section of the kidney. The Staghorn calculi will be located or will be lodged in the pelvocalycial system. That is the part which joins the uppermost part of the ureter. So when it lodges there, your kidney still continues to produce urine, but the urine cannot move down the ureter because of the stone that is obstructing the pelvocalycial system as well as the outlet of the ureter. So that initially, the urine will stay inside the kidneys and will cause edema. So that on the early onset of chronic pyelonephritis, you will have an enlarged edematous kidneys. Now, the buildup of urine in that area will cause pressure atrophy, which will later cause tissue necrosis. Now, when tissue necrosis, the most vulnerable tissues in the kidney to necrosis are your renal tubules. So that your renal tubules will undergo necrosis. The necrotic part will later be replaced by fibrous connective tissue. So, when fibrous connective tissue develops, this will cause contraction of the kidney. So that in the later part of chronic pyelonephritis, you will have a very small contracted kidneys. So this is a small contracted kidneys. You can see that the pelvocalycial system is dilated because of a Staghorn calculi like this one. So a portion of the Staghorn calculi blocks the outlet or your ureter, the upper part of your ureter, so that the renal medullas are being obliterated and you will have a very thinned out renal cortex. So by this time, the kidney is very small. Microscopically, again, as what I've said, the glomerulus will always be and involved. So it is always the renal tubules as well as the interstitium. So this area supposedly would have been occupied by your renal tubules. But because of the ensuing inflammation, tissue necrosis will occur and the necrotic renal tubules will be replaced by this fibrous tissue. Later on, your fibrous tissue will contract. Now, this part of the kidney is filled with mononuclear inflammatory cells or your chronic inflammatory cells. So as what I've said, when some parts of the renal tubules will undergo necrosis and they will later be replaced by fibrous connective tissue will contract so that normally, these are actually your renal tubules. Normally, your renal tubules are elongated, diba? But because of contraction, they become ovoid or circular. And because of the ensuing inflammation that is still present in this organ, it will also cause atrophy of the renal tubular cells lining the individual renal tubules. Now, these injured renal tubular cells will secrete this proteinaceous, homogeneous pink material, which will make the kidney appear like it's a section from the thyroid. So this is now called the thyroidization of the kidneys. Another part, these are your supposedly longitudinal renal tubules. Because of massive fibrosis, they will contract. Another thing is, aside from the thyroidization of your renal tubules, presence of this homogeneous pink homogeneous material being extruded or being secreted by the injured renal tubular cells, you will also notice thickening of the blood vessels or hypertrophy, particularly the muscle part or the medial part of the blood vessels, medial hypertrophy of the blood vessels. Diba? Because of fibrous tissue contraction, this will cause a decrease in the caliber of the blood vessels. And in order to continuously supply the amount of blood needed to perfuse, to oxygenate the entire organ, the blood vessels will have to exert more effort. And the only effort it can do in order to defeat the increased pressure opposing the flow of blood is to increase its muscular part. So there will be medial hypertrophy. So when you hear the term chronic pyelonephritis, diagnostic microscopic findings are thyroidization of your renal tubules and medial hypertrophy of your renal blood vessels. Again, most common etiology would be nephrolithiasis or kidney stone. Acute glomerulonephritis. In cases of acute glomerulonephritis, this time, the renal tubules, and in some instances, your interstitium will be spared. In acute glomerulonephritis, it is your glomerulus. The glomeruli are all involved. Now, there are 4 terms that you have to remember when we talk about glomerulonephritis. There is diffuse, focal, global, and segmental. Diffuse, what does it mean? When you hear this term diffuse, meaning to say, if the kidney that is damaged, you take it out and you examine all the glomeruli in that damaged kidney, all the glomeruli will show damage. That's diffuse. When there are only when only a portion of the glomeruli in that damaged kidney is involved, you call that focal. So there are only focal areas in that damaged kidney where the glomeruli are injured. For global, in global, you are considering only those damaged glomeruli. And if you examine the damaged glomeruli, if the entire globe of the glomerulus is involved, that's global. If only a portion or a part of that damaged glomerulus will show the injury, that's segmental. So let's go back. Acute glomerulonephritis. So you will see this, common signs and symptoms. What do you see in the child? So most prominent is periorbital edema, particularly at the early onset. Later on, the patient will manifest generalized edema. And then what is this? Tea-colored or smoky, dark-colored urine. So those are the two manifestations of a patient with glomerulonephritis. This is commonly seen in children, particularly associated with a 2-week prior history of streptococcal infection, probably strep throat or skin infection. So you commonly identified among children or pediatric population. Aside from that, when you do physical examination, what else will you find out? Vital signs. Why?
Hypertension. Hypertension.
Yeah, why will the patient or why will the child manifest?
Low perfusion. Kidney low perfusion.
And then, what happens when there is low perfusion?
Will cause the kidney to produce lots of renal.
Very good.
5 points.
So, microscopically, this is what you will find. So, as what I've said, in glomerulonephritis, you don't take into consideration the adjacent tubules because most of the time, they will appear normal. It is your glomerulus, the individual glomerulus that is involved. In acute glomerulonephritis, what happens is that there is antigen-antibody reaction. The immune complexes will be deposited in the glomerulus. They will be trapped and they will activate inflammatory cells as well as your complement. So this is now responsible for the inflammatory reaction. In doing so, you will the ensuing inflammation, the antigen-antibody reaction or the immune complexes entrapped within the damaged glomeruli will attract inflammatory cells. They will also trigger proliferation of your mesangial cells. What else? Your endothelial cells and your epithelial cells. So your glomerulus basically is composed of endothelial cells lining these individual capillaries. You have your epithelial cells, your podocytes, and your mesangial cells, which is the connective tissue that holds your epithelial cells and your endothelial cells. Now you have to remember that when there is proliferation of these cells plus presence of inflammatory cells attracted to the area, this will cause an increase in the size of the glomerulus so that they will tend to obliterate the Bowman space. So let's go back. There's a picture of a normal. See? The Bowman space is very, very prominent in a normal kidney. But in cases of acute glomerulonephritis, this prominent Bowman space will become obliterated. So, or narrowed. Now, there are many forms of acute glomerulonephritis. The one with the poorest prognosis is your crescentic glomerulonephritis or your rapidly progressive glomerulonephritis. So again, the renal tubules in the background will appear normal. Although in some instances, the blood vessels in the adjacent area will also manifest. Not specifically for glomerulonephritis, but there are other pathology conditions which involves the glomeruli, which will also cause or bring about changes in the thickness of the blood vessel walls. So another form, obliteration, complete obliteration of the Bowman space and seemingly normal renal tubules. Then we come to diabetic nephropathy. Cellular injury or tissue injury brought by diabetes mellitus is secondary to the toxic effects of sugar in the blood of the patient. Now, the morphologic condition seen in diabetic nephropathy is the classical Kimmel-Steele-Wilson nodules, or your nodular sclerosis. So this condition is focal, meaning to say not all the glomeruli in the damaged kidney is involved, and it's segmental. There are only portions wherein nodular formation is observed. These are actually walls of your blood vessels, or your capillary blood vessels. Now, in diabetic nephropathy, not only are you going to observe the damaged glomerulus or glomeruli, you also have to watch out for cellular changes or histologic changes in the adjacent blood vessels, because some of the blood vessels will also undergo hyaline degeneration as well as sclerotic changes. So nodular. Above there is a thickened capillary blood vessel. Another one there is an almost obliterated blood vessel with hyaline degeneration. Again, for this one, most of the tubules, the renal tubules, are unaffected. Now, your diabetic nephropathy, you have to closely differentiate it, or you must be able to differentiate it from the histologic changes you are going to encounter in lupus nephritis. Systemic lupus erythematosus is an autoimmune condition which damages many organs, and one of the organs involved are your kidneys. So they present with a classic malar rash, or your butterfly rash, although this is not seen most of the time, or this is not necessarily seen in all the patients with SLE. So in the kidneys, again, the glomeruli are involved. What is classical finding for your lupus nephritis are the wire loop lesion, C-shaped or circular thickening of the capillary walls. So it could be C-shaped. This one is a little bit circular. So you have to close, because sometimes if you are not very keen, they will appear as nodular sclerosis from your diabetic nephropathy. But you will always observe a lumen. Now, you also have to watch out for the blood vessels. The renal tubules in this case would appear normal, but the blood vessels will also become affected. So some of the, there will be thickening, and there will be fibrinoid necrosis. Now, fibrinoid necrosis is classically associated with autoimmune diseases, particularly those involving or antigen-antibody reactions lodged in the blood vessels. Lupus nephritis. So your lupus nephritis, just like your diabetic nephropathy, will only be seen focally, so not all the glomeruli in the damaged kidney, and segmentally, not the entire globe of the glomerulus will show wire loop lesions, and not all parts of the globe of the glomeruli or the damaged glomerulus will show your sclerosis or your nodular sclerosis in diabetic nephropathy. Now, in renal amyloidosis, okay, what is the pathophysiology behind amyloidosis? Abnormal protein folding, no? So the abnormal protein folding, this kind the individual cells in our body creates proteins. They use it as a framework for the cell and for other substances, for enzymes or other stuff. Now, when there is a defect in the abnormal protein folding, these abnormally folded proteins cannot be processed by the body, and they have to be extruded out of the cell. In some instances, they can be seen intracellularly, and in some instances, they could be seen outside the cell. Now, these pink structures are your amyloid bodies. So, this one, they are using a Congo red stain. That is a stain used to identify. That is a special stain used to identify the presence of amyloid. So, for this case, the injury will be diffuse, meaning to say all the glomeruli in the damaged kidney will show amyloidosis. And blood vessels will also show this. Basement membranes of the renal tubules will also manifest amyloid. Now these are the damaged glomeruli, and you can see that if you view the entire slide or the entire damaged kidney, all the glomeruli will show this damage. And the changes seen in the glomeruli is this homogeneous pink-like structure, which is actually your amyloid. So blood vessels, in some instances, the entire glomerulus will be replaced by this pink homogeneous material. Also, you can see this on the walls of the arteries or in the blood vessels adjacent to the kidneys. Now, the renal tubules seemingly would appear normal. And microscopically, you will see that the glomeruli, the damaged glomeruli will all appear larger than the usual diameter or size of the normal glomeruli. We come now to the renal tumors now. So what I've said, renal tumors could be benign or they could be malignant. In most instances, they will have to be surgically removed. The first tumor that we're going to discuss is renal cell carcinoma. This is the most common form of renal cancer among adults. Renal cell carcinoma. Grossly, they could either be seen in one of the poles of the kidney, like this one, lower pole of the kidney. In some instances, they will be seen in the upper pole of the kidney. When you cut through the tumor, you will see that its cut section will be yellowish to grayish white in color. Now, they will appear to be encapsulated, but actually they are pseudo-encapsulated. There is no actual tumor capsule. But you can readily identify where the tumor begins and where the normal kidney tissue, renal tissue begins. So this is what I've said, pseudo-capsule. There is actually no strands of fibrous connective tissue that separates your tumor cells from the renal tubules. But you can readily identify where the tumor ends and where the kidney, normal renal tissue begins. Now, the individual tumor cells are polygonal in shape. They have abundant abundant granular cytoplasm or foamy cytoplasm. Now, because this is a malignant neoplasm, you will see that, or you will be able to appreciate the non-uniformity of the individual tumor cell nuclei. Some are very small, some are quite large. And you will notice that they will all manifest a strong intensity of color or a density of color, meaning to say that the nucleus is active metabolically. Now, the most common form of renal cell carcinoma is this type, clear cell carcinoma. Clear because the cytoplasm appears clear. There is another variant of your renal cell carcinoma, which is your papillary type, like this one. And they have this classical papillary formation with fibrovascular cores. So most of the time, if you completely excise this tumor, the patient can survive for long periods of time without undergoing chemotherapy or radiotherapy. Most of the time, what doctors do is they remove the entire kidney with the tumor, and you have to note for tumor invasion in the renal veins. So the patient will have a poorer prognosis if the renal veins will show islands of tumor cells. Next to your renal cell carcinoma is your angiomyolipoma. This is self-explanatory. The tumor is composed of 3 tissue elements. Angio meaning blood vessel, so it could be vascular, it could be bloody when you cut through it. Myo meaning to say this is some portions of the tumor is supported by smooth muscle cells, and lipoma. Now your cut section, when you cut through the tumor, will depend on which of these tissue components is predominant. So if it's angio, when there are more blood vessels, your cut surface will be bloody, at the same time reddish. If it's myo or lipomatous, you will have a yellow muscle part. Now this is again, just like your renal cell carcinoma, this will also appear as it were encapsulated, but this is actually pseudo encapsulation. These are atrophied renal tubules. This is a tumor, an angiomyolipoma, where the myomatous component, the smooth muscle component, is more prominent. And an angiomyolipoma where the vascular component is more prominent. And this one, surgeons are very keen in excising this tumor because of its very bloody aspect. You can still see islands of fats here, fat globules. So angiomyolipoma. This is a benign tumor. Then you have Wilms tumor or your nephroblastoma. Your Wilms tumor is the most common renal malignancy among the pediatric population, particularly among children aged 2 years old to 5 years old. So this is the most common. Okay, by the way, before I forget, your renal cell carcinoma will present with a classic triad. What is the classic triad for your renal cell carcinoma?
Nephropathy.
No? Hematuria, flank pain, and flank mass. So, presence of a flank mass associated with flank pain and hematuria. In an adult, most 90%, 95% of the time, it would be renal cell carcinoma. Now, for your Wilms tumor, as what I've said, this is the most common tumor in the pediatric population, particularly children aged 2 to 5 years old. You will have this large mass. They would begin at the flank, either in the left or on the right flank, but they tend to cross. So that when they are brought to the clinic, when the child is brought to the clinic, they will present with an intra-abdominal mass most of the time. Now this is the cut surface of the tumor. You see, it appears to be encapsulated, but it is actually pseudo-encapsulated. Now your Wilms tumor is composed. The tumor itself is made up of 3 tissue structures or cellular structures. The most abundant is your spindle cell component. Then you will have this round cell, your blastema, round primitive cells. And the third component will be your abortive tubules. In some instances, your blastemal cells will attempt to create glomeruloid bodies. So round structures, round nest of blastemal cells, and they would mimic glomerular formation. So 3 components: spindle cell component, tubular component, and your blastemal cells. So this is the tubular component. At the center are your blastemal cells attempting to form a glomerulus. Then the background is a loose spindle cell tissue. Again, glomeruloid body formation by your blastemal cells, abortive tubules, and vast areas of spindle cells. So those are the three components of your Mion's tumor or your nephroblastoma. Urothelial. So this is the last pathology we're going to discuss. Urothelial carcinoma is a malignant neoplasm that grows within the urinary bladder. Now, there is a strong association with cigarette smoking and the incidence of urothelial carcinoma. So this is the cut section of the urinary bladder. Inside are these globular tumor cells. They tend to grow within the mucosa and they dig deep into the submucosa and muscular. Poorer prognosis will be seen among patients with muscular invasion. Now, you must appreciate the normal histology from that of the malignant histology of the urothelial carcinoma. This is the normal urinary bladder. It is lined by what? Transitional epithelium or pseudo-stratified columnar epithelium. Note that at the upper borders, there is this dome shape, your umbrella cells, dome-shaped cellular structures. Whereas in the malignancy, the umbrella cells you can no longer appreciate. Notice the dense staining of the tumor cells, meaning to say they are more metabolically active. In well-differentiated stage 1 malignant tumors, you can still be able to appreciate the basement membrane. So the basement membrane is still intact. So is with your normal urinary bladder. Now, as what I mentioned, your normal urinary bladder is lined by 4 to 6 layers of your urothelial cells. In malignancies, the lining of tumor cells will be more than 4 to 6 layers thick, as you can see in the next slide. So this is beyond 4 to 6 layers thick. You can still be able to identify the intact basement membrane, meaning to say this is still not an invasive form of urothelial carcinoma. You can appreciate, what is this? Cellular division, what stage? Prophase, metaphase, anaphase, telophase. Still remember?
Metaphase.
Very good. Metaphase. So this is the this is the invasive part. This is your smooth muscle being invaded by your malignant urothelial cells. In this case, the malignant tumor cells are haphazardly distributed. You can no longer understand each arrangement. There are no basement membranes. They are not forming what's this? Tubular structures or others, glandular formation. As in this case, this is also a malignant lining of uroepithelial tumor cells. You can no longer identify the basement membrane. It's no longer intact. Underneath, within the submucosa, is the invasive component of the tumor. So the invasive component of the tumor is forming these tubular structures. So I think this is the last. So that's the last of your slides. Unless you have other questions. So our lecture will be at ABR 2. Okay.